Good morning, ladies and gentlemen, dear chairperson, panelists, and colleagues. Good morning. My title is Transradial Retrieval of Broken Catheter After PCI, a Nightmare. I am Dr. Shahin Kobir, working as assistant professor in the Department of Cardiology of Ibrahim Cardiac Hospital and Research Institute, Dhaka, Bangladesh. I do not have any potential conflict of interest. So my patient, 68 years old female with BMI high, hypertensive diabetic dyslipidemic lady with prior history of PCI2-OM and RCA 2 years back. This time presented with acute non-ST ACS. Her ECG revealed inferior ischemia, ejection fraction was normal. CAG was performed through transradial approach. LAD has mild disease in its mid part. Stent in principal OM branch is patent. Dominant RCA has 70% stenosis in its mid part. Stent in distal RCA was patent. PLB branch has 80% proximal disease. So our plan was to do PCI to mid RCA and PLB branch was planned. There was severe subclavian tortuosity. You can see the tortuosity. So guide catheter Ikari, 5 friends, and guide wire Sion blue was used to do the PCI. Predilation balloon 2.0 into 8 mm was used to predilate the PLB lesion. PLB was stented by 2.25 into 12 mm days. Mid RCA stenting was done by 2.75 into 20 mm days. So this is the mid RCA stenting procedures with 2.75 into 20 mm days. But there is certain displacement of the guiding catheter before taking final image. You can see there is displacement of the guiding catheter. After re-engagement, there is final distal TIMI3 flow in RCA. Stenting of mid RCA and PLV was done successfully. So there was partial dampening of the pressure. We can see the pressure curve. What can happen? Suspicion of catheter knot. There is partial dampening of the pressure curve. Fluoroscopy revealed a tight knot within the right brachial artery along with the guide wire. You can see there is a tight knot within the brachial artery. Repeated clock and anti-clockwise rotation was done to unloop the knot, but that was unsuccessful. Initially, we done clock and anti-clockwise rotation, but that was unsuccessful. Standard wire 3-5 was advanced to unravel the catheter knot, but failed. Guiding catheter was broken into 2 pieces at the level of elbow due to this repeated clock and anti-clockwise rotation. It was divided into 2 parts. Proximal part of broken catheter was removed through the radial sheath. You can see the proximal part is coming down through the sheath. Retrieval using a snare wire was attempted several times but failed to hold the distal broken part. Finally, the 6-French JR guiding catheter was advanced and the distal part of the broken catheter was captivated into the guiding catheter. You can see the captivated part of the broken catheter within the 6-French JR guiding catheter. And it is coming down through the radial sheath. This is the broken catheter was removed successfully through the ipsilateral radial sheath. You can see the JR 6-French guiding catheter captivated the Ikari guide catheter, and it is coming through the radial sheath. These are the retrieved parts of the catheter, distal and proximal part. So a great relief indeed, as there is no vascular complications. Contrast was then injected from the sheath to confirm patency of the brachial artery. So TR access has nowadays become a standard of care for CAG intervention. However, this novel approach may lead to severe catheter kinking and twisting, and further manipulation may be required to unravel the catheter and avoid complications. Etiology may be multifactorial. Excessive manipulation combined with significant vessel tortuosity results in increased resistance and loss of one-to-one torque, resulting in a higher chance of downstream looping and kinking. Probability of vasospasm due to significant smooth muscular component of the brachial artery is an important factor also. A non-surgical retrieval is the treatment of choice for removal of the intravascular foreign body. These techniques are already described by the previous presenter. Gentle rotation of the catheter to the opposite direction, advancement of 3-5 wire, external fixation by a BP cuff, snare delivery, long sheath technique, wire balloon technique, and sheathless guide wire retrieval techniques, etc. How can this be prevented? It can be prevented by using the left radial approach for TR procedures. Try to avoid rotation of catheter for more than 180 degree. Maintain a guide wire in the catheter lumen, if necessary through the Y connector, and monitor carefully the pressure tracing during manipulation. It's very essential for us. So my conclusion is intravascular fracture of catheter is very uncommon. Extra care should be taken while engaging an Ikari catheter using the TR approach to minimize the risk of excessive twisting, which may lead to catheter fracture. All retrievable techniques are part of the endovascular procedure practice and need to be known and applied where necessary. So this is my hospital. I am from Dhaka, Bangladesh. And this is my cardiology team. And thanks for your attention.
Is this a recycled catheter or is it a brand new catheter?
It's a reused catheter.
Was the guide wire inside the catheter when the catheter broke, or I mean, because you were very lucky to be able to get the.
I think the PTC wire is inside, so it is the most important part that helps.
So the guide wire was inside.
Yeah.
So that allowed you to
to bring it through the 6 French GR guiding catheter.
Okay. So that's a good take-home message. Leave the guide wire inside in order to have control of the
Before
of the
taking
broken
final
catheter.
images, we should keep the guide wire inside the guide cath.
Okay. Anything else? Yes. There's a microphone over here if you want.
Actually, I was he's one of the best fellow of my hospital, and I was one of the criminal who has done all these jobs here. But the thing is that also in the previous cases, because in my hospital actually 99.9% cases are transradial, and for me I'm a little bit in a cylinder class, so 5 French guide catheter I use in about 90% cases. So always just to keep 2 or 3 points which I can tell that I can share you with these things, like some of the, not branding the names, some of the catheter companies like Terumo's, and like if you use the Cordis catheter, if it is 5 French even, it's a little bit harder. So kinking is a little bit less. But if it's Terumo, it goes fast. It is very trackable, but at the same time it has chances for the knotting is more. And pressure dampening is a very most important part for any intervention cardiologist to understand. Because whenever you will see the pressure, usual pressure is dampening all on a sudden, then chances of knot is there somewhere else. So because otherwise you don't see all these things for these things. And 6 French guide catheter to use this is the first time what I have used there, because when all techniques are failed. So this may be a new arena to understand these things, to unknot these things. Thank you very much.
Your point is well taken. Just for the fellows or the juniors here, angioplasty starts from the basics. So you have to have good guiding support. You have to understand your catheters. So it's best that you get used to a particular kind of catheters. And I agree with you, the Cordis catheters are a bit most. If I use Cordis catheters most of the time, in fact, almost always, try not to shift from catheters to catheters unless you're absolutely sure you know what you're using and how they react. Because the minute you have a devastating complication, just from a simple lack of understanding of your catheters, then you're going to be in a lot of trouble as well.
Can I just ask, my comment is, the one note I had was also with 5 French Ikari, and I think it's really important because it's quite a soft guide, and especially what we did at the time was trying to do both coronary arteries and also try to engage a graft and so on. But one thing I didn't completely understand from your case, when you were trying to put the guide wire in, when you had a knot, you did not have the guide wire through. So how? And you mentioned at the end.
It is already within the guide catheter. You just see the picture. There's a wire already inside. Okay, this is snare, this is guide wire, and this is the guide cath.
So the guide wire. Was it the 035 guide wire?
Yeah, this is. No, 1.4 guide wire. 1.4 guide wire. This is 1.4.
The angioplasty through.
Yeah.
Okay. And so when you then put just your JR4 guide,
Yeah, GR6.
it was 6 French.
Yeah, yeah.
Was it a JR4 6 French guide?
Yeah.
Yeah. How did you actually fix it inside the distal part? Did you put a
I-
balloon,
I
or
just
did you trap it?
I just glide over the wire, and then captivated the 5 French Ikari catheter.
So you didn't need to trap it or anything.
No,
so it
no,
just
no.
was quite surprising. The other thing, as someone mentioned before, when we had this case, yours was an ideal case really to put a BP cuff, fix it approximately, and you would not actually, you
Yeah.
probably had a much better chance to unknot it.
Yeah.
And what on your video, which is supposed to is pushing forwards and backwards, was exactly which has caused, snatching your Ikari.
Yeah.
And the other thing is the advantage of a BP cuff. You induce, ischemic mediated vasodilation, which would be very useful also. And the technique which is also described, instead of using GR4, just exchange to a long sheath, which sometimes can do a similar thing.
I think BP cup may be a good option for external fixation.
Would be an excellent kind of anatomical position in your case.
Thank you.
I would say, just one last comment, is what we are going to learn in this session is how to solve these unusual complications. We will probably never see one of those, but if, that can arrive, and it's also very interesting to share. Because of that, we will know what to do in case we have something like this. So if there are no other comments or questions, I want to thank you very much for your presentation, and we're going to move on to the next speaker.